So it's now time for a question for the three talks. Is there any question in the audience? Yes, Ramin?
Luis, excellent presentation, very beautiful images. I have a question. You had a case in which in the structural OCT you have subretinal fluid, and your OCT-A showed a dead tree, and you based your decision on the OCT-A. How to be sure that not treating this patient lead to a better prognosis than treating patient?
Okay, excellent question. Thank you so much for. I don't have an answer for that because I have many doubts in these patients. You know that was an example that perhaps we're basing our treatment decision basically on spectral domain OCT or subsurface OCT, but adding some information, some valuable information that could be provided, for instance, for OCT angiography, could change our mind in some cases. But I think that at this point, we should be very cautious, and perhaps we should treat our patients in a regular way, considering the gold standard that we are using today. But perhaps these new diagnostic tools can be very helpful in the future. But I don't have a definite answer for you.
I agree with you, I mean, on the fact that we have to be very cautious about the decision we take. Actually, maybe it's a little bit early to be sure. We keep in mind that, as you said in the last line, we just analyze the flow, the detectable flow. We don't analyze the vessel, okay? There is a wonderful paper from Rick about it. So you just have to keep it, you have to keep in mind, we have to keep in mind that it's just the flow that we are able to detect or not, and not the change of the vessel itself.
Salomon, my question is not far from the previous one. In all your talks, we see that there are clues of activity and clues of inactivity of vessels. But if there is no fluid, is it sufficient at the present time to take a decision? For example, in a patient followed with a PRN strategy, if you have a morphological change in the OCT-A and no fluid, is it reasonable to treat at the present time? Eric?
So your question, I didn't talk about activity, I talk about maturation of vessels. But okay, for the question, Yves, I cannot refuse nothing to you, you know. The question you ask is it possible, or can we treat the patient based only on OCT-A, and particularly when the SD-OCT actually is dry and we don't have any exudative features? So when we treat the lesion, we treat mainly the activity of the CNV. We don't expect with the drug we have today, the anti-VEGF, to remove the CNV or to make it disappear, but to make disappear the consequence of the CNV, the exudative features. Actually, with the drugs we have, maybe it will change in the coming years, but this is the only thing we are able to do. We would like to see a regression of the vessel, and we are able now to see it with OCT-A, but the main therapeutic action and therapeutic response we can quantify and analyze is on the B scan of OCT today. Probably it will change, but I'm not, maybe you are, but I'm not confident to treat the patient only on OCT-A, actually. It seems to be a little bit premature. Maybe you have other opinion, Rick?
No, I have a question.
Oh, okay. Question?
So here's my question. We look at fractal dimensions of blood vessels, and that's a kind of interesting thing to be able to say, oh, this patient's active or not. But in reality, we're also looking at the B scan and we see fluid. It's not a miracle that we can diagnose activity just by looking at OCT, not even have to look at fractal dimension. But what we really want to know, we want to be able to predict how soon will that patient be active again, say in a treat and extend protocol. Have you looked at not the vessels themselves necessarily, but other things that may predict the recurrence of activity? Do they have a big dark halo? Is that a predictive thing? Is the chorea capillaris flow underneath that predictive of them becoming active again? Do you have any information about that?
La question, c'est...
It's very difficult now, but perhaps the combination of fractal dimension and also area measurements can help us to predictive the status, but not the, comment on dit la vitesse?
The speed.
Not the speed, but the status. And perhaps before the apparition of fluid.
Thank you. So you imagine you have OCT-A is a kind of wedding between OCT and FA, and you imagine a third party that is the treat and extend to incorporate the concept of treat and extend with the measurement of the flow. Yes, it's interesting. Maybe it will be the next step.
If I could, you know, for me in an ideal world would be to look at the OCT angiogram when a patient comes in, say based on your pattern and these other features, I can predict that you're going to recur.
Can it be predictive of the activity of the lesion? For that, we need a prospective study.
Yes.
Only a prospective
Yes.
study will answer that, and no retrospective study can. To my
Maybe
mind.
we can think of one.
Yeah.
And
Yeah. One
the mic.
question.
Thank you. I'd like to thank you for the last presentation. It's great, great images there. My presentation in the afternoon is going to be when OCT is the clue. You gave us a lot of clues today, but in my presentation, I have two cases and I'll open it for discussion. When OCT-A, you can only depend on it in the diagnosis and follow-up, because sometimes you have an active lesion with a very high flow and nothing corresponding in the B structure scan. There is nothing, especially in
Good
children
comment.
when they have a complicated CNV. Second thing, in AMD, in very early cases, like you detected before even complication, you have flat irregular RP detachment with a very high flow down there. In both eyes, vision is fine, and again, during the follow-up of these cases, you might regret that you didn't treat this patient. So sometimes OCT is the clue, and I will not burn my presentation, but I think in the afternoon we will open that, because sometimes OCT is the only clue, and you don't find anything else in the other multimodal imaging. Thank you so much.
Thanks. I will come. Thanks for your comment. Other question, comment, or do you
Have a
want
comment
lunch?
for us, a comment.
Yeah.
How do we interpret cases like that they presented without any macular fluid at any time, and that they present a clear choroidal new vessels on the OCT angiography?
You mean the quiescent?
Yes. No, not quiescent, not
Non-active?
not in any time, during all the
Okay, we don't
all the
remove,
follow-up?
the CNV is still there.
Yes.
Okay, we know there is still the CNV. We can detect the CNV. Maybe we can see some difference in the flow, but it's not active. There is no leakage. And we are not able to remove the CNV to make it disappear today. So we can just observe it, and we don't say we do nothing. I learned from her father that we don't say we do nothing. We say we observe. And we observe, and we continue to have the follow-up on this patient.
But do you consider that they are risky lesions and they should be monitored closely or perhaps in a regular way?
Okay, again, only prospective study will answer that, and maybe next year. Thank you.
Thank you.
It's lunchtime now. Thank you.